The triad that you're looking for, chest pain, sure. With that bigger thickness of the left ventricle wall, you're going to have angina because maybe perhaps you can't supply enough blood. Heart failure, late finding. Remember, early on, the left ventricle is lifting weights. And so therefore, is it possible that your ejection fraction could be preserved early on in aortic stenosis? Sure it can. So your ejection fraction would be, what exactly? Your stroke volume over EDV, isn't it? So therefore, when you have aortic stenosis early on, your ejection fraction could actually be preserved. Please be careful. Do not confuse that with congestive heart failure, as we shall see later on. Now, as you continue and there isn't proper management of your patient aortic stenosis, guess what happens? That ejection fraction is going to get compromised, and you will go into major heart failure. And if you do, at that point, that's a bad prognostic indicator. Here we go. There's the S1 and S2. What did we say about this? A crescendo, decrescendo, right? Because the aortic valve doesn't want to open immediately. Tell me about the left ventricular pressure. Increased or decreased in comparison to aortic pressure? Increased left ventricular pressure. You remember the area underneath that curve? The discrepancy between those two curves represents aortic stenosis. Where do you hear this? Right upper area, right? So you find that right upper second intercostal space. That's where you find aortic stenosis to be the loudest. It would be radiating where? To the carotid. And lastly, in terms of S2, well, which second heart sound will then close first? Pulmonic followed by aortic. What's this called? Paradoxical splitting. Do you remember that? So with S2, I told you that there are particular heart sounds that you want to pay attention to. Physiologic versus widened versus fixed. In this case, we are paradoxical. The physical examination, you would expect the left ventricle to work really hard because of increased pressure. And so therefore it will be hyperdynamic. And it's enlarged. But it's left ventricular hypertrophy. You want to make sure that you catch your patient early on with aortic stenosis, because if that ejection fraction starts dropping, what I say about prognosis? Dismal. You don't want that to happen. So I need you to be astute, please. Next, an important point is this. Something called pulsus parvis and tardis. What this means is slow and late carotid pulse due to wide. Pay attention here. Left ventricle wants to eject blood during when? During systole. Your patient has bicuspid aortic valve. Wow. What kind of calcification? Dystrophic. Resulting in aortic stenosis. What happened to cardiac output? Decreased. So when you have decreased cardiac output, then what happens to the pulse and such? It's delayed. So slow and late is what it's called. Pulsus, parvis, and tardis. Slow and late carotid pulse due to what? Delay in blood flow across that stenotic aortic valve. It is that simple for you to understand. Are you going to have differential pressures here? No such thing. Differential pressure, give me diagnosis. What do you mean differential pressure, Dr. Raj? Increased pressure in upper extremity, lower pressure in the lower extremity. That's differential pressure. What's your diagnosis? That's your coarctation of aorta. So be careful. You want to try to bring in differentials here.